So we want to take a moment here. I want to welcome everybody to the grand rounds for today, May 25th. The activity code is listed there for you for today's session. If you are interested in CME credit, please make sure that you do claim that credit before midnight tonight. I'm going to go into, on the next slide here, I'll go into some information just briefly for those who have not yet registered. So we'll take a look here, and it does show that you just need to, if you have not already registered, please text your email address to the toll-free number listed there. And then if you've already registered, you can just text attend, and then the code that is listed there for today, you'll send that message to the toll-free number. I'll put that information in the chat box here again in just a little bit, but if you have any issues, please feel free to reach out to me. Next slide. So as we get started here, I want to remind everybody, if you could please make sure that your microphone is muted, and if you would also be attentive and engaged in the session. I know that if you do have any questions, please feel free to put those into the chat box, and we will be addressing those towards the end of the session. We'll take some time for questions or comments. And then also later on in the presentation towards the end, I will be putting in the evaluation link if you can help us out with the feedback on that. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AHEC, and you can see our mission statement there. Next slide. For those who are interested in claiming CME credit, please make sure that you do that registration again before midnight tonight. But you will want to make sure that you periodically check your CME transcripts. So you can do that at the CME office website listed there. You can call them, or you can also contact me if you have any issues or questions though. Next slide. Also, for those who are members of the AAFP, if you are interested, this presentation does count for credit in the AAFP system. So please make sure you claim credit there. And if you have any issues with that, you're more than welcome to reach out to them or contact me as well. Next slide. One of the other things we do want to make sure we mentioned that it is our goal during each of our sessions to address these nationally established physician core competencies that you see here. So please take a look at that and just let me know if you have any questions. Next slide. And of course, we just need to make sure that we mention that Dr. Cancino has no financial relationships with ineligible companies to disclose. Next slide. And so we do have Dr. Cancino here with us today. He's a senior medical director, and he's the director of at the primary care center. So I'm going to let him get started on his talk and give more of an introduction of himself. But his discussion today is on value-based care.
Great, thanks, Nicole, and thanks everybody for having me. Yeah, today we'll be talking about value-based care. And I'm really honored to be here, really honored to be speaking to all of you. And I'll give a little bit of an introduction to myself in the context of the presentation. So I'll just sort of hop right into it if everyone's okay with that. So here are our objectives for today. I'm gonna describe just very briefly a little bit about myself. We'll spend a moment defining value-based care. And then what I wanted to do today as part of this presentation is really explain how value-based care works, focusing on the Medicare program, the Medicare Shared Savings Program specifically, and then one of our Medicare Advantage programs. We'll talk a little bit about and discuss whether or not value-based care is achieving its stated goal, and then identify areas where I think we still need to improve as well. So before we start today, though, a few quick disclaimers. First is we'll be focusing on Medicare and Medicare Advantage programs today, but as many of you know, there are different kinds of federal, commercial, and state-based value-based care programs out there. For example, if you've heard of TIPS or DSRIP, those are value-based care programs, although run slightly differently than the ones we'll be describing today. But I think if you understand how Medicare and Medicare Advantage value-based care programs work, it'll give you a good foundation to think through value-based care in the future. Second disclaimer is we're going to talk about costs of healthcare today, which can be uncomfortable. I think as physicians, especially in our training, that's often one of the things we are not often worrying about. But especially as we're talking about value-based care, the value equation itself uses cost as one of its components. And so it is important that we think about and talk about cost as we talk about value-based care. And so why is this important to family medicine? Well, as many of us know in primary care, fee-for-service care just isn't working, right? But the pandemic itself really highlighted the benefits of value-based contracts. And a lot of insurance companies are going all in on value-based care. CMS, or the Center for Medicare and Medicaid Services, has a goal to tie 100% of reimbursements to value-based contracts by 2030. So for many of us and many of the residents on this call, many of the jobs that are going to be out there are going to be utilizing not fee-for-service care as the model of care that's being delivered, but value-based care. And so it's important to understand how it works. In our department specifically, and in our professional lives, we need to understand value-based care to be able to strengthen current and create future care management models for our patients. We already do this with the promotoras, the behavioral health consultants, clinical pharmacists, but I think there's more opportunity there. Many practices have gone all in on value-based contracts. And many of you, if you're residents and you're looking for jobs out in the community, either here or nationally, you'll find organizations like ChenMed, Oak Street Health, Geisinger, Conviva, Humana, WellMed. These are practices built upon value-based care as the foundation on how those practices do their work. So it's really important to understand how this works. And, patients today that we are seeing in the clinic, they can benefit from this knowledge as well. And we'll talk a little bit about that. Another reason this is so important, which is something we'll come back to at the end, is that there is a recognition at the highest levels that perhaps the way we've gone about implementing value-based care nationally needs fixing. And so this is a recently published commentary about the new strategic goals for the Center for Medicare and Medicaid Innovation, CMMI. And there's a clear recognition that it's time to go back to the drawing board, go back to the people delivering the care as we think about what value-based care looks like in the future. And so because of this appetite, and because we will be asked our vision of value-based care, it is actually important to understand how it works today as we set the vision for the future. And so a little bit about myself to start, because I don't think I've met all of you yet. I'm a family medicine physician. I did my residency training at the Mayo Clinic. After Mayo, I decided I wanted to learn more about quality. And so I did an academic family medicine fellowship at Boston University School of Medicine's Department of Family Medicine, where I got my master's in health services research. A lot of my research at that time really focused on patients with depression or depressive symptoms and on hospital readmissions as well. After fellowship, I got a job as chief medical officer of a federally qualified health center in Mattapan, Massachusetts, which is about 15 minutes south of Boston. And in that role, really did a lot of work about building an integrated behavioral health department and utilize promotoras or community health workers, as well as licensed independent clinical social workers and substance abuse specialists to help take care of patients in that federally qualified health center. We had a school-based health center. Actually, we had 2 school-based health centers as well as satellite locations for our clinic. In that role, I helped stand up a Medicaid accountable care organization, which delivered value-based care to patients with Medicaid, and really was excited to come here to UT Health San Antonio to help oversee our primary care center. And you see probably some familiar faces in this picture here, a lot of family medicine physicians in that photo, and key faculty and staff members for our value-based care strategy here at UT. In my current role, in addition to overseeing our 7 primary care locations, I also help oversee and oversee the work specifically in care management being done in our UT Health San Antonio Accountable Care Organization, which is called Regional Physician Network. The RPN, as we call it, has a little bit over 40 outpatient primary care clinicians working together to deliver value-based care to our traditional Medicare patients. So really, my job is super interesting. And so again, I'm really happy to be able to speak to everyone here today. So I wanted to start out by defining value-based care and sort of using this as sort of the working definition for the presentation today. So here's a pretty simple, straightforward definition. So value-based care is the reimbursement that ties care delivery payments, right, to quality metrics and rewards clinicians and healthcare systems for efficiency and effectiveness. It's viewed as an alternative, although an unlikely full replacement to volume-based payments or productivity or fee-for-service care, which happens a lot still in healthcare. And ultimately, value-based care, as currently designed, works to incentivize clinicians to improve care delivery, coordinate care, and assume the risk of cost and quality of care for taking care of patient populations. Earlier models of this were really focused on just measuring and reporting, and this was about 10 or 15 years ago. And as payers and providers got better at measuring quality and reporting quality, performance elements slowly were introduced. Over time, the quality reporting was coupled with understanding costs of care. And really the ultimate goal of a lot of what's happening nationally is for clinicians and healthcare systems to ultimately bear the financial risk of taking care of patients. And so, we'll be using these definitions and really this trajectory as we go through the talk today. But I think what is first important is that we define value. And thanks to thought leaders like Dr. Don Berwick and Michael Porter, who many of you are probably already familiar with, we have a starting point in terms of the definition of value, which many institutions honestly have adapted in various ways. And so value, in our definition today, will be value equals quality divided by cost, okay? And just like any math equation, as we think about value, quality, and cost, to increase the number or the left side of the equation, we either have to increase our performance on the numerator or decrease the denominator, right? And ultimately, though, if we were to take this definition and then try to operationalize it, first in terms of what happens in practice as we are taking care of patients, and how current value-based contracts have incentivized action. I like to use the following sort of definition, right? So if value equals quality divided by cost, how are we defining quality? And, I go back to sort of the Don Abedian definition of quality metrics, but I like to think of it as sort of process and outcome metrics, right? Colon cancer screening, diabetic foot exams, doing annual wellness visits in the clinic. Those are process metrics, right? Did it happen or did it not happen? And then obviously outcome metrics. What is the outcome of the care we're providing? Diabetes control, blood pressure control. Is the depression getting better? What are our patient experience measures? So those are sort of the quality metrics that in practice, I think we're all used to thinking about. But this is how we would apply them and operationalize them to this type of equation. Cost is, again, can be complicated. For me, I like to put them in certain 3 types of buckets, right? Acute care costs, so ER visits, urgent care visits, hospital admissions, hospital readmissions, post-acute care costs. So those are things that happen right after a hospitalization. Perhaps the patient goes to skilled nursing facilities or an inpatient rehab or an LTAC, or things that happen out in the community, home health, referrals to specialists, radiology, and hospice. So that's, when we think about the value equation, those are important components to think about. Now, for me, like I said, many organizations have adapted this equation to their practice. I'd like to add on another component, and I call it the population component, or some have called it the community component. What about the patients themselves that we are taking care of? How many patients are we taking care of? And also, how complex are the patients that we are taking care of? So, for our working definition today, if we were to use this, so value equals quality divided by cost, multiplied by the number of patients we're taking care of, and how complex that patient population is. All right. Now, at the outset, I said that we would be really focusing our discussion just on 2 payers, traditional Medicare and Medicare Advantage plans. But, there are value-based contracts, value-based care type models connected to a lot of the different insurances that our patients have. For me, if you understand how it works with Medicare or Medicare Advantage plans, you have a good foundation to start with in terms of how this is done in some of these other models as well. And that includes things like DSRIP or TIPS, or our Community First programs, even costs as it relates to programs like CareLink as well. Now, one thing that can be confusing, and this is one slide with a lot of information, is the difference between Medicare and Medicare Advantage plans. And so, as a rule of thumb, Medicare is a national program for patients who are 65 and older, end-stage renal disease, or ALS, right? And so patients can sign up to Medicare if they qualify using that qualification criteria, no matter where they live in the United States. What Medicare Advantage is, and this is oversimplifying it a bit, but I think it's, it helps you see the difference, is when a commercial insurance company goes to CMS and says, look, if you let us take care of patients who would normally qualify for Medicare, we promise as a commercial insurance company to provide exactly the same services that traditional Medicare would. But as a commercial insurer, we want the freedom to impact cost and quality using our own methods. And if we maintain that cost and quality while still providing everything that Medicare would normally provide, in terms of the cost of taking care of these patients, we as the insurer get to keep what's left over. And so that's Medicare Advantage, right? And so I would just draw your attention to the examples of value-based care type organizations under Medicare versus those under Medicare Advantage, right? So for example, Southwestern Health Resources Accountable Care Network is the UT Southwestern Accountable Care Organization, which is under Medicare, right? Or we'll be talking about WellMed today, which is really owned by United Health, which is a Medicare Advantage plan. But you'll find that there are a lot of similarities between how these types of plans have operationalized value-based care, which is impacting the care our patients receive, and also, the work that we as physicians are providing. Value-based care contracts utilize several different types of incentives to, impact that value equation. Shared savings, which we'll talk about, quality bonuses, utilization bonuses, care coordination, for example, we get incentivized to do hospital transitions of care appointments, for example. Risk coding bonuses. I think many of you have already heard from me about HCC coding and how that helps our population health management activities. And then star ratings, which are publicly reported quality metric performance data from insurance plans. Something that we need to talk about today, because it figures into the rest of the conversation, is this idea of shared savings. And I wanted to talk about that just a little bit. So to understand shared savings, we have to understand this idea of capitation. And so the definition is there, right? The fixed dollar amount per patient per unit of time paid to a clinician for the delivery of healthcare services. Another way you can think about capitation is, an allowance. You have a certain amount of money predicted to take care of a certain group or a certain patient over the next year. And if you spend less than that amount of money than that was predicted, you may get to keep what's left over. That's shared savings. If you spend more than your allowance, then there are potential financial or other penalties involved. So that's the idea of capitation and how it figures into shared savings. Now, on the right there, you'll see the reference on the bottom, is a really good paper from Milbeck Quarterly, looking at the evidence around different primary care systems across the world. And using, and it was really meant to drive policy making at the national level. When this paper looked at capitation as a way to successfully take care of patient populations, it did state that capitation could help reduce overall costs of care, but, and this is something we'll come back to, impacts on quality of care and access to care need to be carefully monitored, because in this review article, they did see differences, some impacts on quality of care if that wasn't closely monitored, in addition to programs that implemented capitated payment systems. As a quick aside, I do think it important to sort of talk a little bit about this. And so I've dedicated one slide to it, although it's a complicated question. Value-based care models have a lot of assumptions within them. But one assumption in terms of how current value-based care models have been implemented is that clinicians, that the cost of care in the United States is very high because fee-for-service incentives have led clinicians to overuse medical care. And a lot of value-based care models currently, take that assumption to heart and have operationalized and created incentives around driving down the overuse of medical care by clinicians. Something to be aware of as we kind of think about value-based care is that there has been a lot of research that has demonstrated that the cost of healthcare in the United States is very high, not because clinicians are, either purposefully or unknowingly utilizing or overutilizing healthcare, but because things in the United States just cost more because of how, U.S. economics finances work. This is a great study here from The Lancet that really looked at this. It compared healthcare spending in the USA to 5 other countries that have higher healthcare spending proportionally to their budgets: Germany, Switzerland, Netherlands, France, and Canada. Even amongst this group, the USA has high healthcare spending. But the study really looked at what was driving those expenditures and came to a conclusion that other studies found, which was that things in the United States are high cost not because we've been overutilizing healthcare, but because things cost more in the United States based on how those prices were set. Another thing that was interesting in this article was that the study period was when Medicare Part D, which was drug coverage, was enacted in CMS, and there was an impact of increased access to Medicare increased access to medications through Medicare Part D. So I just kind of wanted to say that as an aside. There's a lot of research happening on the cost side of these things that is very interesting to those that would be interested. So how does this all work, in practice? And we're gonna focus on this first part of the equation here: value equals quality divided by cost. And let's see here if my slide's gonna work. There we go. So starting with Medicare, we're going to focus on quality metrics, and then we're going to look at areas of costs, right? What Medicare says is, it's no surprise. Here are the quality metrics that will figure in to how we assess the value of care that is being delivered to our patients who have Medicare as their insurance plan. And so, many of these things are fairly straightforward, but it is important to sort of know how it compares and contrasts with a Medicare Advantage plan. So what are the quality measures for our Medicare patients? So CAHPS, or the Consumer Assessment of Healthcare Providers and Systems, this is patient experience. Every year, sometime between October and January, patients in our accountable care organization get a survey, and we're assessed by our performance on that survey. So that's the CAHPS survey. And then remember our quality equation, a number of process metrics: screening for depression, and did we document a follow-up plan, fall risk assessment, flu vaccination, tobacco use screening and intervention, colorectal cancer screening, breast cancer screening, statin therapy use, right? And then we have outcome metrics. So how did we perform, and did we perform better than us or our peers in certain measures? So depression remission at 12 months, that means was someone's PHQ-9 score lower than it was 12 months previous to its measurement. Hospital readmission rate, admission rate, diabetes control, and then blood pressure control. So these are the quality measures that Medicare uses as it determines the value of our healthcare that we provide here at UT Health San Antonio, or for anyone in an accountable care organization. Now, what about cost? So Medicare and Medicare Advantage plans look at the total cost of care for a patient population as it determines, whether or not the total cost of care of our patient population was more than or less than what was predicted. And so what I am showing on the screen now are some of these areas of healthcare utilization, which are bolded. And then, the average cost of some of these utilization events. Right, wrong, or indifferent, this is how much some of these things cost. For example, on average, an emergency room visit may cost somewhere between $500 and $1,500 per visit. A clinic visit, with a specialist or a primary care physician who has Medicare could cost somewhere between $50 and $250 per visit, and so on and so forth. And you can see some of the high cost areas, for example, LTAC, inpatient rehab, which is IRF here next to post-acute admission, home health, which is $1,500 per month on average. Taken to the population level, can really add up in cost, right? And certainly, many of you spend a lot of time in the hospital helping take care of patients that are admitted or readmitted to the hospital. So it's probably no surprise, the average cost of care for a hospital admission or a hospital readmission for a traditional Medicare patient. So what about the other part of the value equation, the community or the population part of that equation? I will say it's one of the more complicated areas of study. And at the end of the presentation, we'll kind of highlight why that community component or that population component is so complicated. But panel size matters, meaning if the predicted cost of taking care of a patient population obviously goes up if that patient population grows. So that's number one. Number two is, and this goes back to the HCC coding discussions that I've had with some of you, risk scores do matter, meaning if an insurance company understands that we're taking care of a more complex patient population than predicted, that insurance company may increase the predicted costs it would have taken to take care of that patient population. There's a limitation, though, when you look at the differences between a traditional Medicare or a MSSP ACO or a Medicare Advantage value-based contract, in that in a Medicare ACO, because of how the benchmark, which we'll talk about, is created, there is a very low limit to how much risk adjustment can be applied year after year. So if we're all of a sudden taking care of a more complex patient population than we were, say, 3 to 5 years ago, we are, in the current model, are not, the adjustments likely will not align with our patient population as we would like. In a Medicare Advantage model, that difference in complexity can make a big difference in what the predicted cost of care could be for a patient population. The last thing I'll say is patient attribution is important. And so another way of thinking about patient attribution is like knowing who the primary care physician is for any given patient. As you can imagine, if a patient sees more than one different primary care physician in a given time period, determining who the true primary care physician is just clinically can be quite frustrating or confusing to the patient. But as it relates to these value-based care models, linking patients to the correct primary care physician or primary care team is actually very important as it relates to the two things I just said, right? Which is, how big is a panel size and what is the complexity of that panel size. Now, WellMed, which is a Medicare Advantage plan, utilizes several similar techniques as traditional Medicare to determine the value of care that's being provided. And so we can go through a little faster here because it's pretty straightforward, right? Similar to traditional Medicare, you have your outcome measures and your process measures here. In fact, some of these measures are quite similar to what's in traditional Medicare, although you'll see under process measures, medication reconciliation after a hospital discharge is a quality measure for WellMed. And you'll see here quite clearly that risk adjustment utilizing HCC coding, so this is percent of conditions addressed, meaning percent of HCC codes addressed compared to predicted, is a quote unquote quality measure for WellMed, which highlights how risk adjustment or coding to the true complexity of the patient that's in front of you can impact the value of care that's provided for a WellMed patient. Focus on care highlights one of the agreements Medicare Advantage plans have with CMS, and that agreement is Medicare Advantage plans negotiate with CMS to create other different models of care to create higher quality or to decrease unavoidable costs, maybe different than a Medicare patient would normally receive. And one of those types of care that are provided by WellMed practices is a type of visit called a focus on care visit, which I won't get too much into, but just know that that's sort of a different model of care than a patient who has Medicare would typically receive. And one thing we'll talk about is that the performance on quality measures then impacts the percentage of the shared savings that is actually collected by a practice. Similar to Medicare, Medicare Advantage plans tend to experiment or with other types of quality measures that don't necessarily clearly impact revenue or patient outcomes, but they track things to make sure that they're still happening in a practice. For example, you'll see here that specific measures like medication review, pain assessment, medical attention for nephropathy, obviously things we're doing anyway in primary care, are tracked very closely by WellMed, even though it doesn't have a quote unquote weight to the value score that WellMed gives a practice. So that's the quality metrics for a Medicare Advantage program, and you can kind of see how it compares and contrasts to traditional Medicare. And when you look at a cost sheet for a Medicare Advantage program, you'll see here that this is exactly the patient population discussion we had, right? Capitated members, this is just the number of patients we're taking care of for our WellMed patient population. An average RAF, which is the average risk adjustment factor, this is basically the average complexity of the number of patients, of that number of patients we're taking care of. And WellMed then assigns a total predicted cost, which they call here a capitated revenue, predicted cost of what it would take to take care of that patient population with that complexity. And then, because it's a shared savings program, documents the utilization events in almost a similar way that traditional Medicare does. And then WellMed tracks and reports quarterly or monthly sort of, you know, how far under or how much over that predicted number our performance or any practice's performance is. WellMed also tracks some standard metrics of utilization like admissions, readmissions, ER visits, as well as utilization of specialists and radiology in a patient population as well. And so, you know, we've talked about the value equation. We've talked about sort of how Medicare and Medicare Advantage are impacted by our performance in these quality metrics, similar to the cost, and sort of how this community or population component figure into value-based care. And I know I've gone through that fairly quickly, and I apologize, but obviously we'll hopefully pass out these slides so you guys can have them for reference. Now, how is our allowance determined? And that's sort of another thing I will mention here. An allowance, or that capitated number, is really determined by a couple of things. Number one, it's determined by historical costs. How much did taking care of this patient population cost, you know, in previous years? Medicare looks 3 years back. Medicare Advantage looks about a year back. How much does it cost to take care of that patient, of a similar patient population in this region or nationally? And is that cost nationally or regionally going up or down? And then how much more or less complex is that patient population compared to what it was? And really, that's how the benchmark, the target, or the quote unquote allowance is set. And then after those costs are processed and compared to the benchmark, the provider keeps a percentage of what's left over. And that percentage is determined by our quality metric performance. And that's how value-based contracts work, right? So we sort of go from this, which is the value equation, which we've been talking about. And in terms of shared savings, Medicare and Medicare Advantage plans go to this, which is shared savings is developed when you have your risk-adjusted benchmark. So our benchmark adjusted to the complexity of our patient population, multiplied by how many patients we're taking care of, and we subtract the cost. And then depending on how we do in the quality measures I just talked about, right? That's the percentage or the proportion of the shared savings practices get to distribute to providers or clinicians or staff or whatnot. And that's how a value-based contract works, using Medicare, Medicare Advantage as examples. So is this working, right? That's the question. Early on, many of you probably heard of Pioneer ACOs. These are really kind of the first 32 accountable care organizations, the Medicare Shared Savings Program in the United States. There are modest reductions in cost if cost was the target. Savings were greater in those ACO members that were expensive to begin with, which probably makes sense. What we see in the literature is that for the most part, quality either slightly improved, greatly improved in some areas, but did not get worse, which is probably a good thing. In terms of the Pioneer ACO model, they saved, across 2012 and 2013, close to $200 million, right? While still maintaining a good baseline threshold of quality in terms of the patient outcomes that we're seeing. And nationally, in terms of what ACOs or Medicare shared savings programs are, how their performance is looking across the United States up until the year 2020, there is an increase in the amount of dollars being saved compared to benchmark, as a whole in these groups. And you'll see that 97% of at-risk ACOs or ACOs who are at risk of having to give CMS money back if they, quote unquote, spend more than their allowance, produce gross savings. So I guess it's sounding good, right? In terms of quality, we've seen great improvements in hospital readmissions in these value-based care organizations. Unfortunately, there is a wide variability in the performance of those other quality measures that I talked about earlier. And again, here's another paper sort of looking at, really it's a review of other articles looking at quality performance. And, we see some improvements, but a lot of these improvements showed wide variability, but no one's, very few ACOs had worse quality as a result of joining the program. Nationally, we are seeing a stable number of patients and slowly increasing number of patients who are part of accountable care organizations. And often patients don't know, right, whether or not they're part of an ACO or not. But we are seeing less Medicare accountable care organizations than in years past. So less Medicare ACOs, more patients being taken care of under these value-based care models. When we look at the Medicare Advantage space, a little different. Medicare Advantage programs, especially during the pandemic, have, have saved a lot of dollars while still maintaining quality in most of the important areas. There are more Medicare Advantage programs available to patients now than in years past, and a higher proportion of patients are now joining Medicare Advantage plans compared to traditional Medicare plans than even 3 or 4 years ago. There are many reasons for this, which we can get into, offline. But we are seeing this as well here in San Antonio and in Texas. Now, as I sort of opened with, signals are pointing towards more, not less, value-based care programs. Like I said, CMS has a really bold goal of, making sure that all Medicare and most Medicaid patients are tied to value-based contracts by 2025. And the pandemic in and of itself, I think, allowed value-based care models to get a foothold in terms of how we're going to take care of patients in the future. One large signal of this is a new direction for ACOs called the ACO REACH model. And REACH stands for Realizing Equity, Access, and Community Health. This is a new model, new type of ACO that CMS is implementing starting January 1st, 2023, which is really taking the feedback of the community and trying to apply it to what we know today as the MSSP model, the Medicare Shared Savings Plan model. Two major differences here, though, and I've sort of bolded those differences. Number one, all participants of the ACO REACH model will be required to have a health equity plan describing how they will reach underserved patient populations. And number two, which is important, is that the risk adjustment piece that I talked about earlier will have a higher proportion of that risk adjustment set aside for risk based on dual eligible status, meaning someone who has both Medicaid and Medicare, and for those patients that come from an area that is in a high area deprivation index. So this is really Medicare's or CMS's way of trying to get to a place, which we don't have right now, where things like social determinants of health and health equity or health inequity matter in the risk adjustment conversation. Another thing that I think CMS has heard is that discussion of pricing in the United States is complicated. I mentioned a couple of papers in this slide and the next, but high prices may not necessarily mean poor quality. A really well-published author named Zach Cooper has a really interesting set of papers around healthcare costs. In a recent paper he published, found that higher priced hospitals delivered higher quality care, which is pretty interesting. And it was an interesting paper I just wanted to bring to your attention. Another set of papers looked at price transparency, which many of you probably have heard about in the news. If we allow consumers to understand how much their healthcare is costing, either their insurer or themselves out of pocket, will that impact behavior towards either lower cost care or something different? But some really good papers have demonstrated that price transparency may not actually lead to healthcare decisions based on lowest price. This is almost akin to like posting calorie counts next to things like menu items, right? But I think, many of you would agree, we've got still a lot of work to do, as there have been other downstream impacts of value-based care, not only on this healthcare system, but on our frontline clinicians and staff as well. We started with the triple aim as the kind of foundation of value-based care. And one thing they sometimes have forgotten to do is ask the frontline clinicians, how do we do this? And Bodenheimer and Sinsky published this really interesting article around, why we need to move from the triple to the quadruple aim, and taking into account the impact of this value-based care on providers or clinicians as well. But even with the quadruple aim, we're not there yet, right? Especially now. There is a big push, both in academic medical centers, to really improve how we have conversations and develop policies around equity and inclusion and diversity. But also now, there's a big push to move towards, from the triple aim to the quadruple aim to the quintuple aim, really injecting conversations about health equity in terms of how we improve in healthcare systems, and ultimately how we deliver value-based care. And these components, were not, on the minds of policymakers 20, 25 years ago, as the conversations about the value equation and the triple aim started to grow. And we have more and more information about the impacts of social determinants of health on health status, right? 40% of the variation of health status is derived from social determinants of health. And Don Berwick published a recent article here called the 10 Teams Challenge, really focusing on the impact of social determinants of health on how we do value-based care, and really what is our plan, right, to impact social determinants of health in the context of how value-based care has been operationalized today. He has a quote in that paper, which I put here at the bottom: "The healthcare industry is not a bystander in the nation's underinvestment in determinants of health, in social determinants of health. It is a cause." And so we still have work to do. Social determinants of health do impact health outcomes, right? We're inching towards solutions perhaps, but certainly in terms of how value-based care has been operationalized, we have billing codes that indicate that patients now have specific social determinants, but those billing codes are not quote unquote HCC codes that are risk adjusting our patient population, right? We also have large upstream problems that, perhaps a frontline clinician is not empowered or does not have the tools to help impact. And so how do we advocate towards policy change, from the front lines of medicine? Access to insurance and timely care are not the same. And so while we are continuing to move towards allowing our physicians access to care through things like CareLink or perhaps universal health care in the future, is the right clinician on the other side of that referral there to see those patients? Benchmarking, as we've discussed, can be flawed. Data continues to be flawed. There's a lot still of what I describe as, in the economics world, describes as asymmetric information, right? This is information that the patient has that perhaps they're not sharing, the primary care physician has, perhaps they're not effectively communicating, and the insurer either has or doesn't have. And so that disconnect between what the patient truly needs in their life to be healthy and what the information the insurer has to implement that care plan, there's still a wide gap. Incentives are still not aligned at the health delivery level, and we continue to have competing demands. We still are asking the question, and we do this today here at UT Health San Antonio: are we measuring the right things for our patients and for us to deliver great care? And can we measure the right things? Is that even feasible? And, is there a path to universal healthcare coverage in the US? And is this the right path? Now, going back to the Viewpoint article that I was referencing at the beginning of this talk, it is an exciting time, especially for the folks, in our department and on this call, is that, the CMMI has released its strategic objectives, new strategic objectives, which I've listed here: driving accountable care, which we've been talking about, advancing health equity, supporting care innovations, and operationalizing social determinants of health in the work of CMMI, improving access by addressing affordability, and partnering to achieve health system transformation. And it's really interesting because when you look at the 17 principles that the AAFP years ago, although last year updated, for value-based care payments, a lot of what CMMI is talking about in terms of its objectives for the next 3 to 5 years are in alignment with the work that's happening in family medicine now. And then the other piece, and I'll touch on this, and I have one more slide, is that it is possible, right, that rigid metrics that I just talked about can create rigid work. And so something that is, but it doesn't have to create rigid work. And something I think we need to think about all the time is, sure, there are always rules and constraints in terms of the work we do, the jobs we have as clinicians, as staff, but these metrics do not need to create rigid work. And I think as we go back to to the quadruple aim that I earlier talked about, it is important to hear the voices of the frontline workers, the folks doing the work as we're creating these new policies and this new direction for value-based care. And so, in conclusion, value-based care is a form of reimbursement, right, that ties care delivery payments to quality metrics and rewards clinicians and healthcare systems for efficiency and effectiveness. We can increase our performance and quality metrics by focusing on the things that we're doing anyway, helping our patients control diabetes, control their blood pressure. We can help our patients decrease, their chance of going back to the hospital after discharge. Right or wrong, what is defined as good performance in our current value-based care world is really predicated on decreasing clinician decisions for higher cost healthcare. We talked about that. And that decisions around value-based care have consequences to our patients and clinicians. But I don't want to overshadow the fact that we know all of this, and this is a great opportunity for primary care, family medicine, folks in our department, to really drive where value-based care goes from here. As I said in the beginning, it's important to sort of know where we are, what is current state, so that we can really help put together plans for the future of value-based care. And with that, that is my presentation. I know I went a couple minutes over than I would have liked, but I'm happy to take any questions if there are any. But thank you for having me here today, everybody. So.
Dr. Cancino, I did receive a message from somebody in the audience directly. If you'd like, I'll read it out to you. There's a couple of parts in it, but it does say, in addition to higher price points for medical supplies, pharmaceuticals, DME, etc., the private practice of medicine as a for-profit business in this country is also a major contributor to higher expenditures as compared to other countries that offer universal access models of care delivery. The US is not experiencing value in terms of infant mortality rate, immunization rates, and many other indicators of health. Two difficult questions. To what extent do you think the for-profit motive impacts our ability to deliver value-based care in a cost-effective manner?
Is that the first question or is
That's the
that?
first question.
Okay.
I don't know if you want to do that one first, since that was a lot. I don't know if you were okay with doing that one first.
Well, yeah, why don't you read that first question again and I'll give it my best shot.
It says, to what extent do you think the for-profit motive impacts our ability to deliver value-based care in a cost-effective manner?
Yeah, it really is an idea of alignment of incentives. And I think the challenge in a quote unquote for-profit world is that there is incentive to do things to create profit. In a world where profit does not matter, perhaps different decisions would be made. And so I think the for-profit motive could have both potential negative consequences in our ability to deliver value-based care. But, again, if incentives were aligned correctly, even in a for-profit world, I could see a system where down the line, both delivering high value, low cost care and creating profit for whatever entity would see that as a goal could find alignment. But I think, yes, but it is more easy to have a mismatch in terms of the goals and priorities when profit is the number one priority. Good question.
Okay, so there was a second part of that, and it said, as the poorest performing state in terms of health insurance coverage, how can Texas FQHCs, CHCs, and nonprofit health centers incorporate VBC methods or mechanisms to improve performance and health status of vulnerable populations?
That's a great question, and I think it's a complicated answer. Federally qualified health centers have been doing value-based care all along. In my previous role, I was CMO of a federally qualified health center. All of the quality drivers and the cost drivers that I mentioned today were in alignment with how HRSA, which funds many of these federally qualified health centers, tracks performance of the qualified health centers. Now, one area where federally qualified health centers can do better in is actually in data collection of its patient population and reporting its patient population's needs, like social determinants of health, other factors, back to HRSA in an aggregated way. That really allows groups like HRSA to then funnel that information up at the federal level to say, look, here's what's really going on in the ground. And are we really funding, this particularly FQHC in the right way? The second piece is, and I'll stop after this, is that incentives for physicians to work in these areas or in these federally qualified health centers may not be high enough. HRSA offers a loan repayment program called an LRP, which certainly does help offset the loans that a lot of first, second, third year primary care physicians have to pay back. And HRSA has a loan repayment program. But there are other factors of why physicians choose to work one location than the other, aside from their salary and loan repayment. And so another way would be to really go back and see what motivates physicians to want to work in federally qualified health centers, and how do we leverage that to increase access for patients in these centers. I'm a big proponent of the FQHC program, which I think does great things for patient populations for sure. I see Dr. Palacios has a question, and I apologize for going over everybody, but yeah, I'm happy to answer your question.
Yeah, mainly it's really just a comment. So, thank you, Dr. Cancino, for such an excellent presentation and for providing such a very good roadmap to help orient us regarding what value-based care is and where it's going. And for for all the residents that are on right now, I just want to emphasize that, you know, a lot of this stuff should sound very familiar to you because it's a lot of the initiatives we've been doing within the FHC over the past couple of years. But as you see, more clinics, more healthcare systems are getting deeper and deeper into value-based care. So especially for those residents that are getting ready to graduate, the sooner you can get a good grasp of what value-based care is, the better starting point you're going to be at your new position, wherever that may be. So I know a lot of this might add some extra clicks on Epic and might mean some more time filling out those attestation forms, but ultimately it's a benefit for both the practice and the patients to do all of this. For those residents on, you know, do your best to learn more about this and ask questions if you have any.
Yeah, thanks, Dr. Palacios. And I'm available to answer anyone's questions offline as well. You know, feel free to send me an email, text me. I want to be here as a resource for all of you. Certainly, I don't have all the answers. You know, this talk probably created more questions than answers for many of you. But I think it is important that you know a lot of this information, and it'll make you a stronger candidate for future jobs as well, just to understand how this stuff works. Any other questions? Okay.
I don't see any other questions. I do want to ask if you're okay with me sharing the slides with today's participants and also your email address with those who may have questions, if you're okay with that.
Yep, that's fine, Nicole. I made a few slight adjustments after you saw, you know, those slides. So I'll send this slide deck to you for sure.
Sounds good. Well, thank you very much, Dr. Cancino, and thank you to everyone who joined. I will definitely get that information out to everybody as far as the slides and his contact information. And then also, you don't have to do it right now, but I did put the link in the chat box there if we can give some feedback to Dr. Cancino as well. But definitely appreciate everyone for joining us. And thank you again, Dr. Cancino.
Thanks, everybody. Reach out anytime. Goodbye.